Thank you, dear Professor Salah, for this kind introduction. It's my pleasure to be with you tonight to speak about an important subject, which is male oncofertility. We all know that cancer and cancer treatments have an adverse effect upon men's ability to father children. It impairs spermatogenesis by hormonal derangements as well as by direct involvement of testicular tissue and the reproductive tract. Indeed, radiation affects directly the hypothalamus and the pituitary, leading to low FSH and LH, and exerts also a direct effect on the testis. The same with chemotherapy, direct effect on the testis, attacking sperm DNA, then spermatocytes, then spermatogonia, then Sertoli cells, and finally Leydig cells are the least to be affected by such insult. Additionally, erectile and ejaculatory dysfunction may result from debilitating physical and emotional impacts of the disease and as a side effect of various medical and surgical therapies. So surgery can be a bilateral orchidectomy or prostatectomy or retrocranial lymph node dissection, and it will remove organs necessary for reproduction or disrupt the nerve supply. So chemotherapy and radiotherapy cure cancer by destroying rapidly dividing cells, and spermatogenic cells are also rapidly dividing cells and are very vulnerable to chemotherapy and radiotherapy. Despite the use of gonadal shielding with radiation therapy, and despite efforts to tailor chemotherapy to be less gonadotoxic, nearly all cancer treatments, while life-saving, will negatively affect and impact male infertility. So statistically, most of men of reproductive age with cancer will survive, and the ability to father children following treatment is a very important quality of life concern of them. Even though many men will recover spermatogenesis following cancer, unfortunately will not recover. And it's very difficult to predict who will and who will not recover after the treatment, because many variables, including type of cancer, extent of disease, doses of chemo or radiotherapy, and susceptibility is quite different in these patients. Additionally, once spermatogenesis returns to normal, it does not rebound to the same level prior to treatment, and sperm quality after treatment is often a concern. It was suggested that generous analogues and antagonists can be used to minimize germ cell and preserve spermatogenesis. Actually, it's an experimental issue, and some promising data have been reported, but it's not a practical one to be advised. The most practical is cryopreservation, which is a standard preservation method before chemotherapy. However, it remains underused, and it can be done for any candidate, adult men or boys producing sperm in the ejaculate and cryopreserve it. Indeed, the advances in assisted reproduction can help us in even after long-term storage of poor quality sperm, can help these patients to have their own children. And high fertilization and pregnancy can result even with severely impaired semen parameters. So it's very worthwhile cryopreserving any live sperm that you can find in these patients. All male requiring chemo or radiotherapy, including adolescents, should be offered the possibility of storage. This is a very, very important preventing pre-therapeutic capability to preserve the progeny after that. And you have to know that semen must be collected before the therapy starts, because if the therapy starts, there is a risk of mutagenesis in spermatozoa. And also it has a significant psychological value because it gives the patient the hope of future paternity. So counseling is very important for these patients, and it should be done before and during and after treatment. And it's very challenging because patients are trying to come to terms with their cancer diagnosis. They have constitutional symptoms of their disease. They are tired. They cannot do an informed decision, and for them providing semen is difficult. And usually cancer treatment often needs to be initiated very soon, sometimes within hours. Also, the patient is not sure how long the sperm can be cryopreserved. Actually, we need to assure patients that there is a report reporting that the patient was using his sperm after 21 years. And I believe it can stay longer than it. Why not? It's already frozen. So it's advisable to tell the patient not to discard sperm until they are certain that they have returned to normal fertility and have completed their family. You need to ask the patient that after treatment he has to use a contraception because there is a risk from chromosomal structural damage that can happen to the sperm, and the contraception is very important. Ideally, 2 to 3 ejaculate samples should be obtained, and this is largely enough to have adequate number of sperm for cryopreservation, and sometimes even one sample is enough because you are going to divide it in many smaller samples. And you know, it's, as I told you, it's difficult for these patients, so sometimes they are unable to masturbate, especially teenagers. So you have to be very gentle in counseling and make the environment very comfortable to collect the semen. And actually, ejaculation is difficult because these patients are anxious, are fatigued, are hypogonadal, have pain, have sometimes diabetes or some neurological problems, or suffering from drug side effect like opium and painkillers. Sometimes we are using this type of machine, electroejaculation, so that we can help them to ejaculate. And sometimes we are obliged to do testicular sperm extraction. Regarding poor semen sample, and we have a nice talk with Dr. van der Zalmen. These patients, many of them have already poor semen sample before starting any treatment. And because the cancer can affect the hypothalamus and the pituitary gonadal axis, and may also injure the germinal epithelium to cytotoxic immune response to cancer or fever or malnutrition. So you can find a variety of severely abnormal semen analysis such as azoospermia, necrozoospermia, oligozoospermia, or cryptozoospermia. And this markedly abnormal semen may jeopardize fertility preservation. So you need to repeat semen frequently in order to get a good sample to preserve. And you are obliged in such cases to do more than one ejaculate. And if you cannot freeze in a sample, you will need to do a surgical extraction. Even in men with a testis cancer, even if he has a solitary testis. So if you have live sperm, it's okay. If you don't have, you need to obtain sperm from the testicles. If the patient is not providing any ejaculate, you have to see if he has a retrograde ejaculation and take sperm from urine. If he is unable to ejaculate, so you need to do vibration or electroejaculation. And if not, you have to go to surgical extraction. After that, you need to advise the patient that if he has radiotherapy, he has to shield his testis to protect it. Sometimes we see patients with testicular cancer, and you need to offer all these patients sperm cryopreservation before going to orchidectomy. And this is very important because even he has a solitary tensis with sperm, he may turn to have azoospermic after removing the testis with cancer. This has happened in 9% of men who have a normal contralateral testis. And you need to obtain ejaculated specimen before orchidectomy. If not possible, you need to retrieve sperm from the testis at the time of surgery, as this may be the last opportunity for the patient to father a child. So some of them will be azoospermic, some of them will be severely impaired. So you need immediately after orchidectomy to take the testis on a sterile backbench. And in these testes, you need to find the healthy tissue from which you are going to do a TESI, and it's called Oncofertility. And you will find some sperms that you are going to cryopreserve and save the future of the fertility of this man. Regarding children and adolescents, these are very special group and must be approached thoughtfully. Sometimes they have undergone puberty with initiation of sperm production, and as adults, they can be affected. Unfortunately, there is no available fertility preservation program at pediatric healthcare facilities, and the knowledge of vulnerability of these individuals to cancer therapy is not that much known, and doctors doesn't know what to tell to such kids and small adults about this issue. So this is very particular. And this group, it's very possible that we can help them, and it has a sensitive approach, and we need a variety of level of physical and psychological help. So puberty is often heralded by nocturnal emission, but sometimes the patient is not sure if he cannot tell you if he has such emission or not. So you take a sample of urine, and if you find sperm, he knows that he can have a sperm, and you can try to have a semen by masturbation, or sometimes by electroejaculation, and lastly by intervention. In prepubertal boys, they don't have sperm, so many investigators are studying the process of germinal epithelial stem cell isolation and cryopreservation. Since 2007, the ultimate goal will be transplantation of this tissue back into the patient after completion of cancer therapy with resumption of spermatogenesis. However, this is purely investigational, and until now, nobody succeeded to have a mature sperm from this type of experimentation, hoping that in the future it will be possible to have sperm from these frozen samples. So this was successful in animal model by xenografting, but not in human till today. The process of sperm freezing are easy. Just you put in cryoprotectants and you go to your freezing machine or in vapor, as Dr. van der Zolmen showed us, and you can use it in IVF or ICSI better than IUI. So to conclude, I need to tell you that cryopreservation is a preventive therapeutic option for oncological patients and offers the chance to maintain the potential parenthood. At the present time, ejaculated or testicular sperm remains the principal established modalities of fertility preservation. Patients need prompt counseling, and they need to know their options for fertility preservation, and they need rapid referral to the appropriate program. And fertility preservation program should offer patients rapid access to an interdisciplinary medical team, including reproductive surgeons, in an experienced ART program that can offer a full complement of fertility preservation technique on short notice. And surgical sperm retrieval requires a reproductive surgeon who is knowledgeable in these techniques, in combination with an andrology lab that is willing and available to work with the patient and the surgeon to coordinate this important service on very, very short notice. Thank you very much.
Thank you, Professor Medhat, for this very comprehensive presentation. And now we have time for some questions and discussion. And firstly, I invite Professor Pierre if he has any comment or question upon the presentation of Professor Medhat.
No, I have only one question. Is in case of prepubertal boy, where are we know in the culture of the native cells, germ cells, artificial, I would say spermatozoa, artificial spermatozoa from germ cells culture? Where are we know?
Actually, we are still at the experimental level. No published success in such procedure. And in Belgium, you are working on that in the AZVUB. You have
Herman Tournay, yes.
Herman Tournay is doing such research, but he's far from having results in the coming few years.
Yes.
And it's the same in other centers doing the same experiment. I don't know when they will succeed. I don't know.
Okay. Any question, Professor Pierre?
No, it's
okay.
Excellent.
Now,
Yes.
okay, thank you, Professor. The big boss, Professor Hassan, if he has any comment or question.
Professor Medhat, thank you for a very clear presentation and for, of course, your experience and leadership in male oncofertility. When you make a contract for someone who will preserve sperm, for how long do you agree on keeping the sperm?
Actually, we agreed to keep it for life, actually. But in our system, we have a renewable contract every 5 years. And so this is a type of long-time cryopreservation. So we ask the patient to come after 5 years and renew his contract. We want to make sure that he's alive and that he's willing to keep his sperm. And so actually, the acceptance is high nowadays. People are more and more aware. And luckily, I have a good contact with a pediatric cancer hospital, and I can start seeing the pubertal boys coming with their family, and they want to cryopreservation. And when we facilitate everything, we make it very fast. They have the fast track. They don't wait. We understand they are very stressed. And this is a very helpful service for this kind of patients, yes.
Any data that long cryopreservation could affect gametes? This is for you and for Pierre also.
I would say there was just a paper published that burst after 27 years storage. Yes.
Okay. 27 is more than enough.
27 years storage. Yes.
I think it's long lasting. Why not?
So there is no effect of
no.
This is what I want to say.
Thank you, Professor Hassan, and Professor Wael, if he's still with us, if he has any comment.
I'm very interested in this topic. That I think that we need to have an awareness campaign in the society, because I don't think that even physician providing an oncology service even is aware or even interested in counseling this issue with his patients. And usually, that's why we face a lot of patients after receiving their chemotherapy are seeking fertility. So I think this is a campaign or a project that we have to work for the sake of our patients.
Yes, actually, this is one of our projects that we are going to work upon it. And as you said, the awareness has to be done at all levels. Chemotherapists, doctors, and nurses, and patients, and everyone who have to do this effort. And we started to do it combined with cryopreservation for female also oocytes and embryos. So this is a combined effort that we are planning to do. It's in our plan, yes.
No, this is perfect. This is perfect.
Thank you. Thank you, Dr. Mohammed. Dr. Anhal, any comment?
I have a question. Can I ask a question?
Yes.
Yes.
Thank you, Professor Medhat. As regards returning of testicular function after radio or chemotherapy, does it differ from a child to a man?
Actually, yes. Actually, if he is a child, I think he's more vulnerable than a man. Most patients I have seen that took chemotherapy while children, I didn't find sperm easily in their testes. In men, I found it more easily. But I'm not aware if there is a study that compared both in children, the prognosis, how it is. But I feel some difficulty for children, yes.
Yeah.
Okay, thank you. Before going to the participants, just can I ask you the last question, Professor Dr. Medhat, if there is any role for medical treatment to improve the semen parameters after chemotherapy or not? This is in patients with azoospermia.
Yes, actually, if you do an FSH analysis and testosterone analysis, and you find that FSH is elevated because of the destructions that happened, you can do nothing. But if you are lucky that the patient has some sort of hypogonadism, you might help him by FSH therapy, like we were talking with Professor Samah. But usually this is not the case. Usually you have high FSH, high LH, low testosterone, and there is nothing to do except doing a micro-TISI. And luckily, some proportion of the patient you can find sperm, and they can conceive. And I have many cases that conceive and have normal children, although they have a long and repeated courses of chemo and radiotherapy. But it's advisable that if you do this TC, you have to stay 3 years at least from the last medical intervention. He had either chemo or radiotherapy. You have to wait 3 years at least.
Thank you, Professor Medhat. Just you have 2 questions from the participant. I think one you have answered, children to freeze for future maturation in vitro at the puberty, whether this is possible. I think that you have said it is possible or just experimental. It's
still in Europe and in what they are doing, it's in university, in special programs, they are doing this. So it's not done in private. It's not done for everybody. So I'm not doing it in my private business because I don't know what to tell the patient. And we are waiting something that maybe it will happen or not. So I cannot advise people in Egypt to cryopreserve for their boards and testes. We need to wait any promising results in the future. And the program for testicular cryopreservation is not the ordinary program we are doing for our adult patients. It's different. It needs a machine. It's a special program. So I am not advising at all our prepubertal child to have such procedure in Egypt.
Thank you. The last question from Dr. Abdulatif Ashur. He stated that chemotherapy or radiotherapy away from the testicle can deliver an irreversible damage to fertility or not.
Yes, unfortunately, yes. Even if the shield is put, even if doctors are claiming using chemotherapeutic drugs that are not harmful, it has a harm. Yes, it has a harm.
And radiotherapy away from the testicle?
Yes, also. Unfortunately, it's harmful, yes.
Yes, okay. The last is, please, Mr. Akram, show us the voting for Professor Medhat. This is the last. For the participant, you have 2 minutes in order to answer these questions. Then we'll come again for Professor Medhat. I should thank you, Professor Wael, for this very, very nice presentation again. Yeah, thank you.
I need to Dr. Pierre Van Zerman. I need to tell you that I have delivery with pinhead sperm.
Oula.
Yes. What we have done, we searched for hours in ejaculate and testicular sperms. And after a very difficult search, we have found some normal sperms.
Okay. You find normal, okay. But you don't inject a peanut sperm.
No.
Okay.
So I have some deliveries with normal.
Okay. For me, when I say peanut sperm, I would say that when you find only peanuts, well, you don't have to inject this. But if,
yes,
okay, I agree with you that you can find.
But some people search, but not enough time, so they don't find, and patient lose his chances. So my advice for doctors that they have to spend hours upon this sample to find the adequate sperm.
Yes, this is what I say in the beginning of my presentation. When we know that we will have a very difficult case, so we design at least 2 biologists on 2 microscopes.
Yes.
They are both looking together, and we start very early in the morning, and even before that they start with the pickups. So
yes, this is what we have to do in such cases.
Only it's a question of organization. Sometimes it's not easy.
Yes.
Okay, we can start the voting, Professor Medhat, about the first question. Despite the use of gonadal shielding with radiation therapy and effort to tailor chemotherapeutic regimen to release gonadotoxic, nearly all cancer treatment negatively impact the male fertility. More than 2/3 of the participants selected the first. True. What do you think?
I'm happy that this is the true answer. This is what the message I need to convey. Yes.
Okay. About the second question, choose the correct answer. Most men of reproductive age with cancer will survive, and most men will recover spermatogenesis following cancer treatment. 9% has chosen this statement. More than about 60% choose the last one, which most men of reproductive age with cancer will survive. A significant number will not recover spermatogenesis.
Yes, the good news is that most of them will recover. The bad news is that a significant number will not recover. So this is the right answer, yes.
Okay. The third question about the GnRH, the use of GnRH analogs and antagonists are used to minimize germ cell loss and preserve spermatogenesis and can replace cryopreservation. About more than half of the participants stated no, this is incorrect.
Yes, it's no, 57%. Theoretically, it's yes, but it's not true. No enough paper to document this or to advise this. So the right answer is no.
But I think the early evidence is in the since some years there are papers appear or publications appear that stated that it may improve the cryopreservation process. Your experience is not with that.
No, I didn't try it, but because this was an old paper and was not confirmed after that by further studies. So people stopped doing it.
Okay. The next question, semen must be collected for cryopreservation. About 90% selected the first before the therapy starts, or during therapy or after therapy.
Yes, it should be done before the therapy, not after the therapy, because we might have an irreversible damage on the sperm, even if they are present.
Okay. The last question, Professor Medhat, male fertility preservation programs should be offered, should offer patients. All answers are true except one. About 39% selected the last answer, which an experienced gynecologist in ART, and about 1/3 selected the first rapid access to interdisciplinary medical team, including male reproductive surgeons. What do you think?
Actually, here the truth is that we don't need an experienced gynecologist in RT, but the other 3 answers are correct.
You always need an experienced gynecologist.
In such program, no. Fortunately, no.
This is prejudice.
Professor Hassan, Professor Medhat says that he is doing sperm cryopreservation and at the same time oocyte preservation. So what should the gynecologists do?
Yes,
We
of
don't
course.
have any rule.
Yes.
Yes.
Okay. Thank you, Professor Medhat. And now I am leaving the stage for Dr. Nihal to present Dr. Muhammad Fawzi. Thank you.